we'll be presenting an interesting case of a syndrome relatively rare, probably 150 cases across the world, and especially the pediatric cases are very, very low. And as per our knowledge, it is the first pediatric case diagnosed of Jalili syndrome in India. So let us see how we reach to the diagnosis. Although the major work was done by our colleagues, so I'll ask my colleagues, Dr. Pavitra, to start the presentation, and then subsequently we take it on.
So, a very good afternoon to one and all present here. The topic for today's discussion is Decoding Jalili Syndrome, Pediatric Dental Case Report. So, basically, Jalili syndrome is a rare autosomal recessive multi-organ disorder which was first reported by Jalili and Smith in the year 1988 across in an Arab family across Gaza Strip in Palestine. So he observed 29 patients in a family and found out a co-occurrence of disorders in two major systems, one involving the dental anomalies and the other is the ocular defects. Now moving on to the case presentation. This case presentation describes a child with the Jalili syndrome who was diagnosed based on a series of evaluation. So initially, a 6-year-old male patient reported to us with a pain in the lower left posterior region for the past 2 months. The history of presenting illness, the pain was insidious in onset, mild to moderate intensity, dull nature, aggravated on chewing and at night, and relieved on medication. Post-discharge was also present. The medical history revealed that there was a frequent episodes of illness and hospitalization during infancy and early childhood due to multiple reasons. The mother also reported reduced tolerance to heat and they were undergoing symptomatic and palliative care for the time being. Moving on to the extraoral features, the child has dolichocephalic facial feature along with the convex profile and hypotrichosis most prominently seen in the eyebrows. The other extraoral features revealed the presence of a discoloration around the umbilicus and transverse ridges similar to Bew's lines were mildly noted on the digits. Now moving on to the intraoral examination. There was a generalized yellowish discoloration with surface pitting and roughness, and there was a hard tissue defect in primary maxillary central incisor extending subgingivally along with the generalized attrition. The child was in the early mixed dentition stage with first permanent molars at various stages of eruption. And their chief complaint was caries in relation to the lower left primary first molar with pulp exposure, abnormal mobility, and tenderon percussion. The other caries lesions were upper left primary second molar and proximal caries were observed in between lower right first and second primary molars. So based on the generalized enamel hypoplasia with altered cuspal morphology, a diagnosis of hypoplastic and hypomineralized amelogenesis imperfecta was made. Now coming to the radiologic evaluation where an orthopantomogram was taken, the OPG reveals peripheral rarefaction with external root resorption involving the offending tooth, that is a lower left primary first molar along with the canine. An atypical resorptive pattern was seen in the lower anteriors along with the radiolucency confined to the peripheral half of the dentin in the teeth on in the second primary molar and proximal regions of second and first primary molars. So the hard tissue defect that was seen in intraorally in the primary anteriors, the IOPA showed that there was a well-defined radiolucency involving the enamel, pulp and dentin extending subgingivally, and this type of root resorptive pattern will be most commonly seen in a traumatized tooth. So now based on the extraoral features, past medical history and intraoral amelogenesis imperfecta, the patient was referred to the pediatrics department to rule out any underlying systemic illness. In pediatrics, the mother complained of diminished vision, complaints of yellowish discoloration of teeth and behavioral abnormalities and attention problems, also gives a history of consanguineous union. So from the pediatrics department, it was advised to go for blood investigations, review in pediatric neurology since the patient was having behavioral abnormalities and attention problems, followed by review in ophthalmology due to diminished vision and genetic evaluation. The blood investigations revealed a mild leukocytosis and moderate eosinophilia with mild lymphocytopenia, majorly of any parasitic infection for which the deworming was done. And pediatric neurology, there was a complaint of behavioral abnormalities. They found there was no change in the cognition, no seizures, no regression, and no movement disorder. Tentatively, a global developmental delay with motor predominancy was made. And in IQ assessment, it was found that the patient was having a mild intellectual disability. In ophthalmology, it was found that the patient was having visual impairment and nystagmus. Fundus examination further revealed that there was a pigmented lesions in the periphery with the signs of dystrophy of rods. Now, with the pediatric evaluation and ophthalmologic evaluation, it was found that the child was having a defect in the dentition as well as in the eyes. So this this directed us towards any oculodental syndrome. So the various differential diagnoses will be discussed by Dr. Nikhil.
So initially, when patient was suspected on the basis of the ocular abnormalities and dental abnormalities, the patient was suspected with AIIMS syndrome, as the features were the retinal dystrophy, the sensory neural hearing loss, the amelogenesis imperfecta, and the other syndrome which was also kept in consideration, that is which is characterized by learning difficulties and developmental delay, peripheral neuropathy, hearing loss, and amelogenesis imperfecta. The patient was referred to the ENT department for assessment of hearing loss, but the patient was observed with normal sensory neural hearing. So these two syndromes were ruled out. Other syndromes which were kept in consideration as these syndromes are consistently reported with the amelogenesis imperfecta. It is characterized by spasticity, epilepsy, the intellectual impairment, the amelogenesis imperfecta. The other is oculodentodigital dysplasia, characterized by microcephaly, the microcornea, the microophthalmia, the dental abnormalities, that is amelogenesis imperfecta or enamel hyperplasia, and digital abnormalities including the syndactyly and midphalangeal hyperplasia. The syndrome which was very similar to our case was the Jalili syndrome, which is characterized by retinal dystrophy, the mental retardation, and amelogenesis imperfecta. So the patient was referred to genetics department for the genetic evaluation. So it was found that there was a mutation in the CNNM4 gene, which is a metal cation transporter mediator gene. So the confirmation of the diagnosis was made with Jalili syndrome, and it was the pattern of inheritance was autosomal recessive. This pedigree shows the consanguinity within the family. The affected child had with both mother and father were considered to be a carrier. However, no genetic evaluation was done for both the parents. Also, mother had a history of 3 miscarriages before the birth of the affected child, followed by 1 miscarriage, and also the another sibling with who's a 2-year-old male has been considered also affected, but no genetic evaluation or has been done. So further, I'll request Dr. Hemlata to discuss the dental management of this particular patient.
So for dental management, comprehensive treatment plan was formulated. In emergency phase, extraction of the first primary molar, this tooth was done as this was the offending tooth. As per preventive protocol, oral prophylaxis and topical fluoride application was done, and swishing and rinsing after every meal was advised. As a definitive phase, restorations of various carious teeth were done. This tooth and the tooth in lower arch was done, and the band and loop space maintainer was fabricated for the place which was here the tooth were extracted, so as to maintain the space for the erupting permanent tooth bud. And in maintenance phase, oral hygiene instructions were given to both the patient and the parent, and the periodic follow-up was done. At 6-month follow-up, we can see the lower incisor was erupting and patient was asymptomatic and the Bannon loop in place. So, in like these cases of with the which are showing the teeth with the structural deformities, usually the full coverage restoration is indicated. Whereas in this case, full coverage restoration was precluded due to the aberrant root resorption of primary dentition in multiple teeth, and further the need for neurological evaluation that is prescribed, the MRI was prescribed, and the child to be periodically followed up until eruption of the complete permanent dentition, and treatment plan to be revised according to the status of the erupted teeth. Also for ophthalmological conditions, various supplementation and prevention of exposure to bright light was advised, and regular checkups and evaluations are suggested to proactively prevent any exacerbation of the systemic abnormalities. Further, the discussion part will be covered by Dr. Pavitra.
So, to the best of our knowledge, this is the first pediatric case reported from Indian subcontinent. Overall, there are less than 150 cases reported originating from the temperate regions. So, the most of the cases being traced from the Gaza Strip, followed by Iran, and Kosovo, a city in the northeastern Europe, has 7 cases, followed by Algeria, Guatemala having 5 cases. Now coming to the etiology, molecular analysis suggests that the mutation in the gene CNNM4 causes Jalili syndrome. So this CNNM4 gene is basically involved in the regulation of magnesium. So this gene is present in the retina and tooth enamel. So in case of retina, the gene is present in the inner and outer plexiform layers where the photoreceptors are developed. So if there is no problem with this gene, the photoreceptors are normally developed, the rods and cones are normally developed, leading to normal visual acuity. In case of tooth, the tooth enamel is formed by amelogenesis, where the magnesium plays a major role. So this CNNM4 gene also plays a major role in the regulation of magnesium. So if there is no problem with this gene, there will be a normal crystal maturation followed by normal enamel. So let's assume if there is a defect in this mutation in this CNNM4 gene, it is going to affect in both the aspects. In case of retina, there will be a problem with the formation of development of photoreceptors. So the rods and cones are deformed, resulting in rods or cone dystrophy. And in case of teeth, it is going to affect the magnesium regulation, thereby resulting in the crystal maturation, causing hypomineralized or hypoplastic amelogenesis imperfecta. Now coming to the amelogenesis imperfecta, there are 3 phenotypes of amelogenesis imperfecta being reported. The first is the hypoplastic type, hypomineralized type, and hypomaturation type. Hypoplastic type is due to any defect or insult in the amelogenesis process that occurs during the matrix deposition, which is characterized by a very thin or defective enamel showing surface pitting or roughness. The second is the hypomineralized type, where the defect or insult occurs during the calcification stage of amelogenesis. So here the enamel of full thickness is formed. However, the enamel is found to be very thin and weak and tend to chip off on mastication. The third type is the hypomaturation type. Again, here any defect or insult occurs during the crystal growth of amelogenesis stage. So here the enamel is again formed with full thickness, but there will be a discoloration, generalized discoloration. So in the present case, the patient was showing the features of both hypoplastic and hypomineralized type of amelogenesis imperfecta. So the diagnosis was made to be, the diagnosis was made to be hypoplastic or hypomineralized type according to Whitcomb classification type 3B, which falls under autosomal recessive pattern as shown in this case. Now coming to the types of Jalili syndrome, there are basically 2 types of Jalili syndrome. The one is type A or infancy onset, characterized by progressive macular defects as seen in this present case. The second type is the early childhood onset with normal optic fundi and without nyctalopia. Now this case has a distinctive feature of craniocephaly, which has not been a stark finding in other cases. So this could be attributed to the novel genotypic variants. So in literature, the other features reported along with the Jalili syndrome are situs inversus, keratoconus, mental retardation, and muscular overgrowth. There is another hypothesis being tested. So majority of the cases reported worldwide are from regions with high concentration of groundwater fluoride. So, a study by Amini et al. Found there is a significant correlation between frequency of Jalili syndrome and the regions predicted to have high groundwater fluoride content. So, the hypothesis is presence of high water fluoride levels, hot climatic condition that results in increased water intake, malnutrition, and genetic diversity in response to fluoride level could expose this particular gene CNNM4 to mutations. So, this case of Jalili syndrome has been diagnosed at an early age through a timely interdisciplinary approach. In children with Jalili syndrome, the optic finding may not be always the initial presenting feature. So, all the healthcare professionals should be aware of the overlying dental manifestations. The take-home messages are careful evaluation, thorough knowledge, and interdisciplinary referrals lead to early identification of underlying systemic conditions. Oral conditions can serve as a mirror reflecting underlying numerous systemic and genetic disorders. So, prior knowledge regarding the associated syndromes will help in early identification and effective treatment planning that would probably enhance the oral health related quality of life of the child. Thank you. Now it's open for discussion. Any questions, please?
So just one question and one contradictory doubt, because the epidemiology says that it has been exposed to individuals who have been more in fluoride region, but in our treatment management also we have applied fluoride therapy for prevention.
Hello. Yes. So for caries prevention, we are not giving systemic fluorides. It is topical, and we know that the topical works. Therefore, it has been given. And this is only hypothesis, it has not been proven. We cannot do a prospective study to find out that. Just a hypothesis. Any more questions? Nobody is listening. सब लोग मोबाइल में बिजी हैं. चलो, if there are no more questions, thank you very much.